All right. Afternoon, everybody, and thanks again for joining. It's really been a fun day doing some live surgery and then, of course, talks this afternoon. It's been enjoyable to see my partners kind of give their take on things and enjoy those talks. So again, really appreciate the opportunity to join you. This talk today is really going to be focused on quality of life. So we talk a lot about surgical techniques and things in the operating room. But that being said, to really optimize outcomes for our patients, it's not just about operating room care, but it's also about a variety of things, pre-op evaluation, post-operative care, and those kind of things. So that's what we'll focus on this talk today. As the WHO defines it, quality of life is really a person's own perception of their position in life. It is a broad-ranging concept, if you will. That's important to note because we think of quality of life and what we sort of assess for our patients. But the truth of the matter is, it doesn't really matter what I think about my patient's experience. It really matters what they think about their experience. And that's really where things like patient-reported outcome measures come into play, or PROMs, we'll call them this talk today. And those are really important to assess both disease-specific quality of life as well as overall or general quality of life. Now, when we think about the skull base arena, there are a number of instruments that are available out there, and it's beyond the scope of this talk today to go through each of those individually. But suffice to say, they're out there, and each one has their own benefits and drawbacks. If you're interested in this, there's a really nice quality of life sort of systematic review that's been done on this. You can see down below that Nick Rowe and I put together. And feel free to look at that if you want to look at individual aspects of these. But in someone who has more of a rhinologic practice and is based on sinonasal quality of life, there are a number of things we think about in regards to quality of life. Certainly, the surgeries that we do affect many aspects of sinonasal function. That's things like nasal obstruction, congestion, crusting, disturbances in olfaction afterwards, and of course, a variety of other things as well. In most people's rhinologic practice, the SNOT-22 is the most commonly collected patient-reported outcome measure. On the call, you guys are all familiar with this. It's a 22-item test, 1 through 5 on each one, with higher scores being worse quality of life, sinonasally speaking, and lower scores being better quality of life. And this can be subdivided into a number of subdomains, which we'll touch on briefly later, including rhinologic, extranasal, ear and sort of facial symptoms, and then psychological and sleep symptoms as well. Now, this PROM has not actually, in its original intent, been validated for endoscopic skull base surgery. That being said, in recent time, retroactively, this has been validated for use in pituitary tumor surgery. So sort of straightforward transcellular EEA, the SNOT-22 score is a validated instrument. And then most recently, just published a few months back, we also validated the SNOT-22 in sinonasal malignancy population by comparing it to the University of Washington quality of life score. So although it's not widely validated across all skull base surgery, the SNOT-22, which we use in our practice routinely, again, is validated for cellular surgery as well as sinonasal cancer surgery. Now, what does the SNOT-22 score do after endoscopic endonasal skull base surgery? This is a really nice systematic review published by Nick Rowe a few years back. And what he looked at was outcomes in the SNOT-22 and really focusing on 4 groups: cumulative SNOT-22 scores, and then patients who begin with a pre-op score of normal or less than 20, and patients who begin with a pre-op score of above 20 or for baseline sinonasal quality of life. And focusing here on the blue line, this is cumulative SNOT-22 scores. What you see is that after surgery for that first month, scores get a bit worse. They go up in number. But then by 12 weeks, 26 weeks, even out to a year or two after surgery, SNOT-22 scores from the cumulative perspective actually improve and typically actually get better than what they were at baseline. Now, when we look specifically at patients who have a preoperative SNOT score of above 20, so preoperatively, they're symptomatic from a sinonasal perspective, those patients almost universally have improvement in their SNOT scores over time following endoscopic skull base surgery. And that may be due to things like getting turbinate outfracts or septoplasty done as part of that procedure. But in general terms, we can tell most of our patients that their sinonasal quality of life actually may improve after surgery in most cases. Now, when you break it down by where the pathology is, this is a little bit of a dichotomy. So blue is an intracranial pathology, and then orange is an intranasal pathology. So like a meningioma versus a sinusal cancer. And what we see is that at baseline and then at long-term outcomes, folks with primarily intranasal pathology have worsened SNOT scores than those with intracranial pathology. And that makes, of course, some intrinsic sense as we think about that. Now, one of the most important quality of life factors we care about in endonasal surgery is olfaction. And the truth matter is the degree to which we will affect someone's olfaction really depends on the location of the tumor and how we manipulate that olfactory mucosa during the surgery. In a case like this, where you're resecting an olfactory neuroblastoma, I expect that patient to have long-term or permanent anosmia following surgery, and they're counted on that, of course, up front. Now, in a case like this with a plain meningioma, there may be a chance we diminish some olfaction, but in general terms, I expect them to remain normosmic for the long term after their surgery once they've healed from the initial insult of the surgery. How do we try to preserve this? Well, as you guys saw earlier today, when we raise our septal flaps, we do our very best to preserve a superior olfactory strip. This is early data from Dan Kelly and Rick Corral showing that with that preserved superior olfactory strip, the rates of objective anosmia postoperatively is quite low with about 5% of patients. And of course, what that superior olfactory strip is indicating, as you saw in surgery today, is making that upper limb incision for your septal flap below the olfactory phelix. Then once you reach the head of the middle turbinate coming upwards, where the olfaction has stopped anterior nasal cavity, and preserving in the picture on the right that superior olfactory strip. Now, that leads us to an important next question. Does what we use to make that incision matter? In other words, does using a needle tip bovie to make that upper limb incision decrease olfaction postoperatively? So we sought to answer that with a randomized controlled trial, which we published about 3 years ago. And what we found was that in a randomized controlled trial setting of using electrocautery versus cold steel cautery for the upper limb incision, there's really no difference in olfactory outcomes. That's based both on objective UPSIT scores as well as SNOT-22 questions focused on sense of smell. So in general, we feel very comfortable making those incisions with electrocautery based on that randomized controlled data. Now, what about in larger cohorts or larger series? How do we do with olfaction following general endoscopic skull-base surgery? This was a systematic review we published back in 2019, looking at all published data at that point in time. So 29 total studies, the majority of which were really focused on cellar or paracellar pathology. And what we found in this systematic review is that using objective measures of both the UPSIT as well as the CCSIT, or the cross-cultural smell identification test, there's really no difference between baseline scores and postoperative scores in patients who undergo endoscopic endonasal transcellular surgery. We also pulled that data together, and again, there was no difference in long-term outcomes in olfaction from baseline to postoperative outcomes, really suggesting the majority of patients getting cellular surgery, we can preserve their olfaction pretty well. Now, in this particular systematic review, we did not look at pathology directly involving olfaction. We also didn't look at particular harvesting techniques for the flap, but again, we looked at previously with that randomized controlled trial. Now, what about someone who may struggle with olfaction postoperatively? Is there anything we can do for them? This was a really nice study done in both Stanford and Emory in a prospective fashion, looking at the role of omega-3 fatty acid supplementation following endoscopic skull-base surgery. And what they did was they looked at, after surgery, patients would get randomized to either saline rinses alone or saline rinses plus omega-3 fatty acids. And what they found was that in the group who got supplementation, there was less olfactory loss at both the 3 and 6 month postoperative time intervals. Now, the degree to which that olfaction was preserved was a very, very small number. So it's limited perhaps, but statistically speaking, at least, there was a difference in outcomes with omega-3 fatty acid supplementation. In addition, those patients with functional pituitary tumors seem to do worse with olfaction than patients with non-functional tumors. So I do routinely talk to patients about omega-3s, and if they're struggling with olfaction postoperatively, I will tell them to at least try this as a low-risk, reasonable thing to do. Again, that's omega-3 fatty acid supplementation. So if we could sort of summarize olfaction data, I would say that a little bit of early olfaction loss is very common, but at least with cellular pathologies, long-term olfactory dysfunction is pretty rare, but really the degree to which we affect the olfactory mucosa is what really matters. And again, maybe a small role for omega-3s in some patients with postoperative olfactory dysfunction. Now, in addition to things like olfaction, there are other morbidities we may cause with endoscopic skull-base surgery. One of them to note is the potential risk for external nasal deformities. We don't think about this very routinely, but here at Pittsburgh, a nice study was done looking back at 328 patients. And of patients who did have some degree of external nasal changes, these were patients who tended to be younger, who underwent surgery for cancers, and all patients who had external changes also had nasal septal flap utilization. So something to think about. This was followed up with a prospective study of 34 patients undergoing endoscopic and nasal surgery, followed by a blinded review of and facial analysis. And interestingly, almost 15% of patients report a subjective external nasal deformity, and about 13 of those were also noted on blinded review to have some degree of objective external nasal deformity. Now, all these patients who had that also underwent nasal septal flap elevation. However, none of them plan to undergo rhinoplasty to address it or repair it. Now, I think this has probably changed with our increased use of reverse flaps, which probably provides some extra vascularity to the septum. But I do talk to my patients about this because you will have some who are bothered by this potentially, again, bigger surgeries, flap utilization, cancer, perhaps radiation as well. In addition, I alluded to this today in the case that we did with the encephalocele in regards to vidian nerve preservation. This was a really nice prospective study of which Eric Long was the first author on, done out of Pittsburgh. And this was a prospective study looking at unilateral vidian nerve sacrifice as part of an approach. It looked at both objective tearing after surgery as well as a validated tearing or dry eye questionnaire. And what they found was that in regards to subjective scores, there was really no difference between the vidian nerve sacrifice side and the contralateral side. However, in patients who had decreased tearing preoperatively, there was an increased risk of having worsened validated subjective scores after surgery. So again, the patient we did today who had baseline dry eye, we really did our very best to preserve that vidian nerve because we know really based on this data that she would have an increased risk of issues postoperatively if we sacrifice that nerve. Now, what about septal flap donor sites? We sort of talked about this a little bit today. That, of course, can be an area of morbidity for patients, prolonged nasal crusting, scabbing, and again, maybe even external nasal deformities. So we do use the spyways, as you guys saw earlier today. That does help to preserve that area. In addition, we've tried other things in the past. So this is some data we published looking at placement of a porcine small intestinal site at the donor site, which really improved crusting over time and also allowed some increased progenitor cells to be incorporated in that area. But really what we do nowadays is we use the reverse flap. And we showed that today in the case. You guys can look at that publication, which is shown here. And this really is a very nice way to reline that septal flap donor site. And essentially in every case we raise a septal flap currently, we put that reverse flap into place, as you can see sort of outlined here. And again, those publications are out there if you want to look those up, but a really effective way to improve morbidity and improve quality of life. Now, what about sinonasal cancers? We've talked a lot about endoscopic endonasal cellular and intracranial surgery, but what about when the nose is the problem, when there's really a tumor in the nose? So I'll touch on briefly on some data we've published using the Corsica database. This is a very large prospective study of about 9 centers. And this is centrally enrolled patient data, so both quality of life and oncologic outcomes, as well as central biobanking of tumor specimens. It's really been a really nice initiative for sinonasal cancer. And one of the early studies on this published in 2023 was looking at long-term quality of life after sinonasal cancer treatment. And what you can see here is a couple outcomes. So on the left is a SNOT-22. In the middle is a UW quality of life physical domain, and then the UW quality of life social domain. What we see here is that baseline SNOT-22 scores are actually quite high. So people are really symptomatic at baseline when a cancer is present, But after their treatment, actually, the SNOT-22 scores drop quite a bit, as you can see here. So again, long-term quality of life outcomes from a sinus-nasal perspective are quite a bit improved after therapy. Now, with the UW quality of life, more of a global scale, higher scores are worse. So they start off pretty bad, they improve and kind of get a little worse over time, maybe radiation effect. But then with their social scores, they generally get worse over time, as you can see here, sort of outline the UW social scores. Now, what factors make that worse? Here we outline the blue line is no involvement of the tumor in the pterygopalatine fossa or the intracranial space. The red line is PPF involvement, and the green line is intracranial involvement. And what you can see across all QOL domains, so the SNOT, the UW physical, and the UW social, is that patients with PPF involvement and intracranial involvement do worse in SNOT-22 scores and both large domains of the University of Washington quality of life score. So those factors do make a difference. In addition, as you can see here, in regards to surgical technique, blue is non-operative technique, red is purely endoscopic, and then green is open, and orange is combined approaches. And similarly, those patients who undergo open approaches tend to have the worst quality of life, both in regards to SNOT-22 and UW physical domains and social domains across the board. And a very nice figure here showing the relative impact of a number of factors here. And you can see, again, open resection, neck dissection, PPF involvement, et cetera. Those are the highest impact factors for the long-term quality of life outcomes you can see sort of outlined here. Now, the secondary question is, if patients have such a poor quality of life at baseline when they're presenting, what factors are associated with it? And this is really nice data, and Dr. Wong was the senior author on this one as well, for baseline quality of life outcomes with sinusal cancer patients. So we broke this down by the subdomains of the SNOT on the left here, and then of course the subdomains of UW, as you can see here, again, both physical and social or emotional outcomes. And in regards to each of the SNOT-22 domains, what factors played a role for worsened baseline quality of life? And as you can see here, the ones that are sort of bolded are you're going to see listed several times. That's skull base involvement, and then of course perineural invasion and palate involvement. So really important when thinking about baseline poor quality of life is, again, perineural spread of disease and involvement of the palate, especially with speech, swallowing, eating, et cetera. Now, what about the UW quality of life? Well, overall, orbit involvement patients had worse baseline quality of life. And then for both the physical and the social domain, perineural invasion was also a big factor for worsening quality of life, and palate involvement as well in that social and emotional domain. So again, looking at this at baseline quality of life, those factors seem to play a really important role at having worsened baseline quality of life. Now, are there other things we're probably missing out there in regards to quality of life? The answer is yes, I'm sure that there are, and we're a little bit limited with the tools we have currently. But I think we can summarize this data by saying that with general endoscopic skull-base surgery, especially in the sellar and parasellar area, most quality of life changes are transient. We can actually maybe expect improved sinusal quality of life in the long term, and olfactory dysfunction is typically temporary and is at baseline by about 3 months or so postoperatively. There are some unique morbidities based on the approach we do. Again, we looked at vidian nerve, intracranial phosphodiesterase for olfaction, a number of very specific morbidities that are really based on the approach we take in the tumor location. And again, there's some really unique considerations in sinusal cancer, both at baseline as well as in long-term quality of life. So with that, I'll wrap up. Again, thank you so much for the opportunity. We appreciate it. And I look forward to seeing many of you in Pittsburgh someday, or if not, as we visit many conferences, et cetera, around the world. We look forward to seeing you there. So thank you for the opportunity.
Thanks very much, Garret. That was a really nice talk looking at quality of life outcomes there for our endoscopic skull-base surgeons, something that we often forget about, and we're very interested in our life or expectancy outcomes rather than quality of life for our patients. So really interesting to see how you manage it and to see the data that you've got there on the olfactory and as well as the use of that reverse nasal septal flap. So thanks very much for that.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.